Awesome. All right. So I'm going to talk to you about some ECMO physiology, and then I'm going to move on to talk about the specifics of COVID and ECMO, followed by a case study which will hopefully illustrate some of the key issues in an ECMO retrieval and your role in it. I'm only going to focus on VV ECMO today because VA ECMO is a whole nother talk. So there are two main configurations that we use in VV ECMO, and I apologise if some of you already know this, but I was asked to pitch it at the 6 monthly registrars. So you've got the femoral jugular configuration where you can see on the left-hand side of the screen, you have a drainage cannula inserted into the femoral vein all the way up to the IVC. That goes into the pump, then the oxygenator, and is returning oxygenated blood via the IJ into the right atrium. And then on the right-hand side of the screen, you've got a femoral configuration. So basically, femoral vein has a drainage cannula up into the IVC, and then the other femoral vein will have a return cannula up into the right atrium. So let's go through each component in a little bit more detail. So you can see the blue line is your venous access line. That's the drainage line, the access line, the negative pressure side of the pump. That drains blood under negative pressure into the pump. Now, we have no access ports on this side of the pump because if a tap were to come loose, you would get an air embolism or entrain air and stop the pump. Blood is then sucked into the pump, so it's a centrifugal pump, and then it pushes blood out under pressure. Now, because it's a centrifugal pump, it's important to remember that it's load dependent. So how much the pump can actually push out is very much dependent on how well filled the patient is, so the preload, and how hard the pump has to push against, so the afterload. And then you come up to the positive pressure side of the pump, and that's where you have the oxygenated blood returned to the patient. Obviously, if a tap comes loose on this side of the pump, you're at risk of exsanguinating that patient. So how do we actually oxygenate and decarboxylate the patient with ECMO? So very crudely, the membrane can be thought of as a lung. So it's made up of these hollow fibres, which you can see on the left-hand side of the screen, and it has this very large surface area for gas exchange to occur. So the membrane has a blood compartment and a gas compartment. Oxygen is continuously applied through a very simple mechanism to the gas compartment. Now, as the blood passes through the blood compartment, oxygen diffuses out of the gas compartment into the blood compartment, and CO2 is removed from the blood compartment into the gas compartment. Now, how much oxygen the machine will actually provide to the patient, though, is very dependent on how much of the patient's cardiac output you can actually capture with the membrane. So the two biggest factors that will determine this will be your cannula size. So the bigger the cannula, the more drainage you'll get, the better the flow, and your flow rate, which you can see illustrated on the left-hand side of the screen, that V number, 4 litres per minute. So increasing the flow rate will increase the amount of membrane fibres that are coming into contact with the patient's blood. So you're increasing the proportion of the patient's blood that's being oxygenated. We normally aim for a flow of around 3.5 to 4 litres, so about 2/3 or 60% of a patient's cardiac output. So that's generally enough to safely oxygenate the patient when they're supported with this. And what about CO2 removal? So as I just mentioned, you can see that blood is continuously exposed to a fresh gas flow. So on the left-hand side of the screen, you can see the green tubing that's connected to a flow meter and a gas source, which is connected to the wall. And that green tubing goes all the way to the membrane. And that's all that it is. That's all that is supplying the membrane with oxygen. You control the amount of inspired oxygen by the flow meter and by the blender, so that the Seacrest blender. It's really as simple as that. Now, we know that CO2 wants to diffuse down a concentration gradient. So if you have a higher CO2 concentration in the patient's blood and a low concentration in the gas compartment of the membrane, then that concentration gradient will be large, and CO2 will be removed quicker from the patient's blood. So if you want to remove CO2 fast from the patient's blood, you increase the flow rate. It's as easy as that. So very crudely, oxygenation is determined by the circuit flow, and CO2 removal is determined by your flow rate, otherwise known as your sweep gas flow. That's about as much physiology as I'm going to talk about, and I'm going to get on to now talking about the use of ECMO in COVID. And we've got quite a bit of experience with it now, both internationally and nationally. So I really want to highlight first that this disease, despite the variant, is still displaying two different types of phenotypes, particularly in the ECMO population. And I want to touch briefly on these phenotypes as they're going to impact on the prognosis of ECMO patients. So we've probably all heard about the H type and the L types that were initially proposed by Gattinoni, who's probably one of the most published researchers on mechanical ventilation in the world. So he described the L type, which is basically characterised by low everything, and that normally happens in the early phases of the COVID illness. It's basically characterised by an alteration in perfusion of the lung. So there's something going wrong with the blood vessels supplying the lung. Patients will have a low elastance, so the compliance is normal. They'll have a low VQ ratio, again, because there's something wrong with the blood vessels. And importantly, their mechanism to have hypoxic pulmonary vasoconstriction is impaired or inhibited. They've got low lung weight, so all you'll see are these ground glass densities on CT, and they've got low lung recruitability, so they're not really going to respond to proning or PEEP. Importantly, they'll have a low CO2, and that's because their minute ventilation is high. Their minute ventilation is high in response to the hypoxia that they're experiencing. So treatment during this phase, as we all know, just consists mainly of high inspired oxygen. Now, during this period, and it's important to remember that they're at risk of developing something called PSILI, which is patient self-inflicted lung injury. Their compliance is normal, but in response to the hypoxia, their minute ventilation is increased. So the patient will not appear dyspneic to you because they're generating these really large tidal volumes that the brain thinks are appropriate for the degree of hypoxia that they're experiencing. But these tidal volumes and these high inspiratory pressures in some people are actually very damaging to the lung. Now, normally, non-invasive strategies like high-flow oxygenation and CPAP are normally enough to maintain gas exchange and get patients through this stage, and you'll see improvement. Now, that's why you're seeing these good survival rates with CPAP. But in the ECMO population, it's the early recognition of those patients that do not improve, and then they start transitioning to this H-type disease that is proving really important for prognostication. So it's being able to recognise the patients where NIV is unable to reduce or settle that high respiratory drive, those high inspiratory pressures, and intervene early with intubation and mechanical ventilation. So we don't want them sitting on CPAP for 15 days, breathing with these really high inspiratory volumes, because basically that'll make them ineligible for ECMO, which we'll talk about in a minute. Now, what predisposes a patient from progressing to the H type is still unknown, because not all patients are going to transition to this H type of disease. Now, the H type phenotype is characterised by high elastance, so they've got a decrease in gas volume with a lot of edema in the lungs, very soggy lungs, and poor lung compliance. They have this high lung weight. The lungs are really boggy. They've got a high shunt fraction. Now, that's because their cardiac output is increased in response to the hypoxia, and they start perfusing dependent areas of the lung, which is why proning and PEEP are going to help these patients. And they've got high recruitability. So these patients are more like your standard ARDS patients, and the ventilation strategies that you employ with these patients are similar to ARDS. Now, I just want you to have these two phenotypes in mind as I talk to you about the selection criteria for ECMO and the outcomes that we're seeing. So who gets ECMO in COVID? Pre-pandemic, we used the Murray scoring system, which a lot of you will be familiar with. It's basically just made up of 4 components. Each receives a score. You add the number up and you divide by 4. And generally, a Murray score of 3 or 4 makes you eligible for ECMO. But as resources became more scarce, the selection criteria became a lot more stringent. Still, though, the criteria for ECMO are still being worked out in regards to COVID. So New South Wales was previously using the Alfred criteria, which was developed during the very first wave. But we realised pretty quickly that the phenotype for Delta was very different for the phenotype for the first wave. So we will still use the scoring system as a guide, and it's actually quite a complicated scoring system to use, as you can see on the right-hand side. But you can see that the triggers for referral are actually quite generous. All you need to score is a PF ratio of 100 or less than 100 to actually trigger a referral. I think the best thing we have is something called the Eolia criteria, which most international centres are using. Now, patients should have one of these three variables to trigger a referral. That's a PF ratio of less than 80 for more than 6 hours, or a PF ratio of less than 50 for more than 3 hours, or hypercapnia with an uncompensated acidosis for more than 6 hours. As the resources became more and more scarce, particularly in the UK, the exclusion criteria broadened. A key factor in the exclusion criteria is the days of mechanical ventilation. And this is where P-Cili and the H-type, L-type actually become quite important. So mechanical ventilation for more than 7 days has been a relative exclusion criteria for as long as I've been doing it. Generally, we say that if a patient has been ventilated for more than 7 days, ECMO needs to really seriously be considered. That's because there are very poor outcomes associated with placing a patient on ECMO if they've been mechanically ventilated for more than 7 days. And that's just because of the injurious ventilation that happens when they're placed on a ventilator. What actually constitutes injurious lung ventilation, though? It's not only intubating a patient and mechanically ventilating them. CPAP now, particularly coming out of this pandemic, is counting as days of ventilation. So if you have a patient on CPAP with a high respiratory rate, so more than 25, a CPAP that's continuous, so they have very limited breaks, a CPAP that allows the patient to generate really high tidal volumes, so more than 10 mils per kilo of their predicted body weight, or the patient's on an FiO2 of more than 60% or a PF ratio of less than 100, we're not going to include them for an ECMO referral. Now, counting CPAP days is important. In fact, you could probably argue that prolonged CPAP use is probably more of a contraindication than prolonged mechanical ventilation, because we can't quantify just how injurious the ventilation is that's occurring with the patients. And lastly, as a general rule of thumb, all patients should have a few cycles of prone ventilation prior to ECMO commencement. However, you've got to remember, proning's not a treatment. It only bides these patients time. So let's move on to the international experience first with ECMO use in COVID. They are also noticing these two phenotypes. So those that are referred early in their disease with normal compliance and or compliance that has only just started to deteriorate, so we're talking about the L phenotype, they tend to have shorter runs. And this is because ECMO is obviously allowing lung protection to occur prior to any sort of irreversible damage setting in. And this is opposed to those that are referred late in their disease with the low compliance, so the H-type patients. They tend to have really long runs, and these are the patients that we're seeing have the superimposed bacterial pneumonias from the profound immunosuppression that they're receiving. And these are pneumonias that are very resistant to treatment. The ECMO cannulas often get seeded with bacteria like Klebsiella, and we just can't shift it. In England, at least 25% of ECMO patients are getting ECMO for at least 5 weeks. So they're really long runs. A 55-day run is really not out of the ordinary. And the chest CT looks absolutely appalling. There's little to no lung parenchyma, but irrespective of the CT findings, particularly in the large centres or the large respiratory failure centres in the UK, the patients are turning around eventually, and we would caution against using CT as a prognostic tool. The international survival rates range from a mortality of around 36 to 54%, which is basically similar to survival for COVID and non-COVID respiratory failure when you're using ECMO, so very similar to the ARDS data. If we move on to the national data, the SARI report takes into account the Delta variant in Australia. So 5% of all ICU admissions for COVID need ECMO, and that denominator is 2,000 patients. So that's actually quite a bit, and there's quite a few patients in New South Wales alone that have been supported with ECMO so far. So let's move on to the local experience. You can see on the screen the survival data from the 4 main centres in Sydney that provide ECMO. During the Delta wave, we were finding that patients were being intubated too late. Patients would struggle along with high flow or CPAP, then they would crash day 20 of their illness. They would require intubation and they would get a rapid ECMO referral. There was also a high incidence of pneumomediastinum, probably due to the P-Cili or the CPAP use where inspiratory pressures weren't well controlled at the time. These patients had longer runs overall and did not fare as well. We've gotten better at preventing patients from progressing to the H-type disease, and we're paying more strict attention to NIV settings with an earlier push for intubation if they're showing any tendency towards P-Cili behaviour. Most of the patients are young, believe it or not. They're in their 40s and 50s. Now, that may reflect a stricter criteria for ECMO, or it just may reflect the disease process. And often these patients are obese, as we know. Importantly, these patients need time, patience, and perseverance. They are really long runs. We've had patients supported with ECMO for over 4 months. The CT looks absolutely terrible, with respiratory physicians wanting to withdraw care, but they end up having enough lung function to make them functional at home. There are a lot of setbacks and there are a lot of complications and ups and downs with these runs, but the persistence and the willingness to institute aggressive therapy is actually key to getting these patients through, particularly when they're so young. So we start rehabilitating them early on ECMO. We wean the paralysis as soon as possible. Now, that's not always possible in the first few days, but we try to get it off quickly. We wean the sedation as much as possible, and we try to get them awake enough so they can move around the bed, so they can start using some of their muscles, because there's nothing worse than having a patient on ECMO for 4 months that's basically paralysed from critical illness myopathy. And we normally perk trachea them early in the ECMO run. So this is a 42-year-old patient, 180 kilos, who was being handbagged at referral because they couldn't generate high enough inspiratory pressures to oxygenate him. He deteriorated late in his illness and was referred day 20 of COVID on the day he was intubated. And this is one of the patients we had on for 4 months. He kept getting those superimposed bacterial infections. He had a standard ECMO circuit, could not oxygenate him because his cardiac output requirements when he was septic were just too high. Now, if you go back to what I was saying about ECMO flow and oxygenation, the cardio help is only rated to 6 litres of flow. In this patient, being both obese and septic, his cardiac output would have been upwards of 12 litres. So we're only really being able to oxygenate about 50% of his blood, and he had no tidal volumes on the ventilator, which you can see illustrated by the chest X-ray. So we ended up configuring 3 oxygenators and 2 machines to support his oxygenation during the acute septic phase from his bacterial pneumonia. And that worked, and that allowed us to maintain his PO2 above 50 just for a short period of time while he was septic, and then we reconfigured back down to a single configuration. Obviously, we wouldn't have been able to do this if resources were limited. And then we've got this 36-year-old male who had a common variable immunodeficiency disorder and severe bronchiectasis of the lungs. His bullous disease was so severe that mechanical ventilation was not an option. He would never have been weaned from the mechanical ventilator. So he was self-proning but was severely hypoxic and in significant respiratory distress. And on top of that, he couldn't perform the physio that was required to manage his bronchiectasis. So we cannulated him awake, and that allowed his oxygenation to stabilise. And he received chest physio on ECMO awake, and that led him to only be on ECMO for 10 days, and he's back home now working and with his kids. So just a short note on Omicron. We're noticing both internationally and nationally this time around that more pregnant women are requiring ECMO. It's a largely unvaccinated population again, but the COVID myocarditis, which is extremely rare, I think we've only had 3, maybe 4 patients recently require VA ECMO for COVID myocarditis in New South Wales. But these patients are all vaccinated and they're young. And obviously the transplanted patients are receiving more ECMO at the moment, and that makes sense because they're high risk. The immunosuppression that they're on renders the vaccine essentially ineffective. All right, so let's work through a case study now to try and illustrate your role as the retrieval doctor in an ECMO retrieval. So you're on road and you've been tasked to Hornsby Hospital to retrieve a 40-year-old male with COVID pneumonitis. He's otherwise fit and well. He's been managed in Hornsby ICU on CPAP for 7 days. He is day 15 COVID PCR positive and day 18 symptoms. He was intubated for refractory hypoxia and worsening respiratory distress. He's had 2 cycles of prone ventilation, but now that he has turned supine for this 3rd time, his SATs are 70% and his FiO2 is now 100%. The only treatment for COVID so far has been dexamethasone. His current vent settings are an FiO2 of 100%, tidal volumes of 400, a peak inspiratory pressure of 40, a PEEP of 15 and a PEEP plat of 30 with a respirate of 30. His ABG is, as you see on this screen, he's acidotic with a high CO2 and he's borderline hypoxic. So What aspects of this history would trigger you to ask if an ECMO referral has been made? So the things that are really concerning me are that his driving pressures are high, indicating that his compliance has now gone off. His minute ventilation, and I think this is the most important point, his minute ventilation is really high and he's still not clearing his CO2, and his oxygenation is borderline. So what other information would you like to know when you're taking the call or when you're talking with the ECMO team? So I want to know how long he's been on CPAP for. Has he had these high inspiratory pressures on CPAP? How long has his FiO2 been 100% for? And what triggered the intubation in the first place? So basically you want to know if there's been any sort of injurious lung ventilation. So an ECMO referral was made. However, the team are finishing up retrieving another ECMO patient, and it's anticipated that you'll be the first ones to arrive to assist in stabilising the patient. So what sort of information do you want to know from the ECMO team on the conference call? The key thing is knowing whether or not you're going to be retrieving with a rotoflow or a cardio help. So in pandemic times, we're able to deconstruct cardiac bypass machines to get the rotoflow out. So more rotoflows potentially will be used rather than the cardio helps, because there's only 40 cardio helps in the state. So you may be asked to retrieve on a rotoflow. A rotoflow is basically a deconstructed pump. So your oxygenator and your pump sit external to the console. Normally we're using an MPV with an extension bridge to transport these patients, but you can use the retrieval ambulance, which you can see on the screen, and put the pump and the oxygenator on that bar that sits across the crash drawer. If you're taking the MPV, you're going to need a standalone ventilator, extra nickies. Remember that MPV extension bridge that I think you pick up from Mascot, and the tie-down straps. If you're taking the cardio help, it's easy. It's an all-in-one system. You use the road retrieval ambulance. You just pick it up and you sit it on the crash drawer, and you just need to remember the tie-down straps and some extra nickies. So you get there before the retrieval team. What can you do to actually optimise the patient while you're waiting for them? So you can paralyse them if they haven't already been paralysed them and deepen the sedation. Find the best available ventilator if they're in the ED. Bring down the ICU ventilator. Recruit them, add some more PEEP, or look at their lung compliance with PEEP and see if you're able to safely do that. Diurese them if you can. Optimise their hematocrit, because when they go into ECMO, they're going to bleed. So you want to ensure that you've got 2 units of PAP cells cross-matched. You want to make sure that they've got large bore IV access, because they can become quite hypovolemic very quickly. And you want to make sure that if they've got a right IJ CVC inserted, that's changed over to the left side, because the right side will be used for cannulation of the return cannula into the SVC. All right, so let's walk through a typical cannulation. I hope these videos work. I'm basically going to show you a mixture of ECPR and COVID ECMO cannulations, but you'll get the drift of what I'm trying to say. Okay, it's not going to work. Okay. All right, so basically what we do is we access the vessel. Hang on a sec, sorry. Now I've got the wheel of death. We access the vessel with an ultrasound. You must always use an ultrasound when you're accessing the vessel. Sorry, guys. And we tend to dilate with the dilators that you can see on the screen. So we dilate up one size at a time, eventually dilating up to the size of the cannula that you're inserting. So here you can see, I wish the video would play, that a large wire now is being inserted all the way up into the RA, and we confirm on tow that wire is actually sitting in the RA. It's just taking its time because it's a video and it's not wanting to share. Once that's done, dilation occurs really slowly, twisting technique that you can see here, and then we go on to ECMO once the cannula is inserted. Sorry. So the cannula you can see here on the screen, it's a large, long cannula. It's got a white obturator sitting in it, lots of drainage holes. That's inserted. We're inserting that in the femoral vein all the way up into the distal IVC. Once we're happy that the cannulas are in position, the lines are clamped, then we release those clamps, and dark red blood is drained into the oxygenator, and bright red blood, unfortunately you can't see on the video, is returned to the patient. All right, so during this phase, what can you do as a retrieval doctor to help manage the patient? Depending on how much circuit flow is achieved, the patient may need filling, as a lot of their cardiac output is being drained into the ECMO circuit, hopefully not onto the floor as in this case. So a lot of these patients have been diuresed to try and achieve a negative balance for their lungs, so filling them may be essential as you go on to try and get flow. Their blood pressure also has a tendency to dip, and they tend to have a systemic inflammatory response to the circuit. So having some metaraminol on hand or even some noradrenaline online is useful too. You may also be asked to give a 5,000 unit heparin bolus as well. Then I want you to turn your attention to the ventilator. This is normally done in conjunction with the ECMO doctor as well, but we transition to rest settings normally. So that's otherwise known as 10-10-10. So we have a rest rate of 10, a PEEP of 10, and a P inspired of 10. Expect that with these settings, in a lung that has already reduced gas volume and is highly edematous, that you're going to lose all tidal volume and you're only going to be ventilating dead space. That's okay. The whole point of establishing ECMO is to rest the lungs, and they'll usually become ECMO dependent at this point. Their PO2 actually drops as they go on, and that's okay as well. All you've done is you've lost native ventilation, so you've increased the pre-existing pulmonary shunt that was occurring. Eventually, their PO2 will come up, but we're just trying to keep them safe at the moment and rest the lungs. So aiming for a PaO2 of 50 or 60 is perfectly reasonable in the early stages. And you want to wean the FiO2 on the ventilator as much as you can. So with sedation, most of the agents that we use are dialysed by the membrane, so you're going to require more sedation than usual. We tend to use morphine and midazolam because they're longer acting and they don't get stuck on the membrane. Propofol and fentanyl do. So if you are going to use them, you're going to need a lot, like a lot. And just make sure you paralyse them for transfer. In terms of your sweep gas flow, we normally set it at 2 litres and we progressively increase that over time. We don't want to reduce the PCO2 too quickly, particularly if you're starting with a PCO2 that's quite high. And that's just because the changes in CO2 will change the cerebral vascular tension, and the rapid changes in the vessel diameter can cause shear stress and micro tears. Now, if you add heparinization to that, you can actually precipitate an intracranial hemorrhage. And basically, the incidence of ICH is around 20% on ECMO, so you want to be really careful. Some centres aren't heparinizing at all until they do a pan-CT scan. Others are just doing this very low sweep until they know what's going on and have a feel for the patient. Packaging the patient, you can see here the rotaflow. You've got the MPV stretcher with the extension bridge, and that rotaflow is connected to the end of the extension bridge. And then with the cardio help in the helicopter, you've got the foot plate where the cardio help is sitting, and that's pretty easy to manage. So lastly, just before you're departing, you should go through some final checks. You want to make sure that you've got adequate oxygen and power supply. You want to confirm with the ECMO specialist your ventilation goals. You want to make sure that all your taps and stopcocks are really tight. The last thing you want is to have exsanguination in the patient, particularly on a retrieval. You want to make sure that your access or drainage cannula is a dark red blood and that your return line is a bright red blood. So that's a very good clinical indication that your oxygenator is working and that you've connected the oxygenator to the oxygen source. Believe it or not, that happens more often than not, that the perfusionist or someone in the midst of a retrieval will actually forget to connect the oxygen up to the flow meter. Make sure that the lines are secured and that they're away from snag hazards, and make sure, as I said, that the patient is paralysed and sedated and that you've got plenty of redundancy in sedation medications. The last thing you want is to have them waking up and coughing. That'll really affect your flows and oxygenation. And I think that is all.
Excellent, thank you, Nat. Take some questions now. I'll just start off. There was one from Alex Zanis on the WhatsApp group. I quote, Alex says, seems to be a move to intubate early rather than trial CPAP in some Sydney ICUs, despite the recovery trial and other data suggesting benefit. The argument might be that silly is worse than villy, so self-inflicted lung injury worse than ventilator inflicted lung injury. What are your thoughts?
Yeah, that's right. That's exactly what I was saying. Not all patients will progress, so that's the problem, and so you really need to have close monitoring. I think by all means they get tried on CPAP and they get tried on high flow, but there's just got to be more stricter attention paid to how they're behaving and what sort of tidal volumes they're generating. And normally day 3 or 4 of CPAP, the intensive care tend to get an idea of which direction they're going, and it's at that point they'll make the decision to intervene earlier and intubate them.
Yeah, I guess it is the hard call, isn't it? Which ones to intubate if they're on CPAP?
Yeah.
That's an ongoing challenge.
Yeah, it's a really nuanced decision to make.
Yeah. Another question, what's the functional outcome of some of these COVID patients post-decannulation? Are they respiratory cripples or are they recovering well? Is it those lungs?
I mean, it's varied. Obviously, it's on the spectrum. So they're starting to do, but this is again from the first wave, lung MRIs in the UK, and these patients are coming back as outpatients for lung MRIs. So there's some degree of functionality there. The patients that we've supported with Delta, at least my local experience in Westmead, 7 of them are back home. A couple of them are working already. Most of them will have some sort of respiratory impairment and functional impairment, but they're back home and they're independent with their ADLs, which is a win considering that these patients were basically on death's door.
Sure, no, definitely. Amazing stuff. Any other questions from the audience before we go to morning tea?
I think we'll Jess's talk before morning tea.
Oh, sorry, Jess's talk before morning tea, cool.
Can you just ask about weight loss for the obese patients in these long runs?
A question about how much weight some of these patients lose during the ECMO run. I'm not sure.
Depends on how much you fill them. Some of them get really boggy and really volume overloaded during this phase, so they put on weight. The 140 kilo guy, I think he was on for 4 months, lost about 20 kilos at the end of the day. But no, I wouldn't recommend it for weight loss.
Extreme weight loss. Excellent. Well, thank you very, very much, Nat. We'll let you get back to your day. Appreciate that very much. Thanks everyone.
Thank you.